that surface hemostat, it will definitely stop the bleeding, but there will be clot formation. So that's why you will not see any bleed. But once you relax and then any extubation time occur, the contraction of muscles, again the bleeding starts. So it is always good for tonsil not to put ferracrylium, because it's always better to coagulate.
Yeah, is it wet cotton ball or dry cotton ball?
Dry, sir, dry.
Dry cotton ball.
I mean, we do not follow wet, but I don't, because as we do not follow, I have not observed the nuances of wet cotton ball. If it has any advantages. You do wet cotton ball, sir?
Yeah, usually we squeeze the saline and we put.
Okay, sir. We put dry cotton ball once again. Good. I am separating the tonsillolingual sulcus. Okay, yeah. Dissector. So pass.
You are starting incision from the upper pole.
Yes, sir.
Good.
So once again, you are able to see, sir, the capsule? Yeah. So that is what, this first step is actually very crucial in getting a good plane, sir, avascular.
Okay.
So take some time for this, then everything will again be easy. Once again, so I was catching the medial part of the tonsil. Now I am catching the superior part of the tonsil.
Yeah.
So once again, separate the anterior pillar now. Let you see the capsule. Separate the posterior pillar, a little bit of this thick fiber.
Yeah.
And then you can peel. I've peeled, sir.
Yeah.
So I call this peel tonsillectomy. This is simple, no cotton ball, no worry of injuring the bed with even dissector. If you get the plane, getting the plane is what matters. So separate this. Okay. Now I think so I've had enough dissection. Now I'll put the snare. Everything is banana peel. Even in septoplasty, you should get that good perichondral avascular plane. It is a banana peel. So once again, go through the snare. Cut. Okay. Now lower pole is bleeding. Okay. So put cotton ball. Suction.
So Manideep,
sir,
in your practice,
sir,
how many times you have brought the patient again for postoperative bleeding, and how you have controlled that?
Sir, I've heard stories from my dad.
Yeah.
Once I came in these 3 years, by luckily my dad's grace, because I don't believe in God. So we have not yet seen a bleed.
Yes.
Yes, we have just one more.
Dr. Madhu is there?
Yeah, he's God to me, sir. He's everything to me. Okay. Sir, I am I'm right now sitting in front of you people and doing this surgery just because of him, how he has trained me, the setup that he has put forth.
Yes.
Yeah. So because of his mercy only, I am right now here. So he is like a God to me. So we'll just relax, sir. Always we should relax, because the constrictor muscle should relax. And if there is any hidden bleed, we can easily find out. I think so, yeah, we'll wait for 2 minutes, and then because it's 9:05, we have put adenoid cotton balls.
Yeah.
It is 15 minutes now. So
yes.
Always pack the adenoids, forget, then come to tonsil, do all your stuff. Sometimes we even, because of the biofilms adenoids, the CRS develops in these kids sometimes, and the maxillary sinusitis will be there in kids. We do antral wash, inferior meatal antral wash, to remove all the pus. Okay. So even we do that. In the meantime, tonsils also will given enough time for hemostasis, and then at the end, we look for hemostasis. And before removing the adenoid cotton ball, I'll show you a beautiful catheter tube. This is epistaxis catheter tube, sir.
Yes.
This is silicon, made
Yeah.
of silicon. So this is very soft, even the, give me a syringe. And this is available with decibel.
Ah.
This has two parts, which inflates the nasopharynx and also the nasal part.
Yeah.
So not just for adenoids also, I think so this costs around only 5,000, and this is autoclavable, reusable n number of times till it lasts. So I think so this has lasted us for more than 50 cases.
Okay.
So if you even look at the economics of it, it is like 100, or even it goes to, if it comes good way, 50 per case, that's it.
Okay.
And this gives a good pressure hemostasis. It's like same Foley's, but Foley's has high pressure and high volume. This is a high pressure, low volume, same like our Eustachian tube. So take 10 cc for Eustachian tube,
Okay.
so 10 cc of air, and then see,
Yeah.
the bulb is inflated. So this acts as a pressure in nasopharynx.
Okay.
And this is silicon, so this is so soft. It is non-traumatic to the tissue also.
Okay.
And I'll show you the nasal part, even in OP cases. Okay, so this has a small nick because of instrumentation. The bulb of the nasal part is gone, but the adenoid, the nasopharynx part is working.
Oh, no
So,
problem.
yeah. Now I'll remove the adenoids cotton balls, and then we'll see if there is any bleeding. If there is any ooze, we usually put this epistaxis catheter and again wait for clotting time to happen.
Okay.
45 degrees scope, forceps.
You don't use diathermy,
Sir,
Manadip?
as last resort, sir.
Okay.
As last resort, because we believe in pressure hemostasis.
Okay.
My father is like, if need of coagulation only, we'll do. Otherwise, we will preserve the integrity of the mucosa.
Okay.
Okay. Yes, sir. Yeah. Scope clean, Sablon.
So if at all there is a bleeding, what is your choice of controlling?
Sir, if coblation, there is nothing better than coblation. If not, then we can have the Stamberger curved suction forceps. I'll just. Suction means curved suction better. There is one more cotton ball lodged in
నాకు
the
మైక్
coina.
ఇవ్వగలవా?
I'll remove it with pull it out from curved suction. Yeah.
హలో
Yeah, yeah.
Yes, sir.
No, he's doing under general anesthesia.
హలో
Sir, dad, sir, I think so you can switch on
Yes.
to dad.
హలో ప్రభాకర్
Yes, Dr. Madhu, we are with you.
యా ఐఎమ్ జస్ట్ షోయింగ్ ఎ టంగ్ టై విచ్ ఇస్
Okay.
వెరీ కామన్ సిచ్యువేషన్
Okay.
ఆర్ యూ గెటింగ్ మై ఓవర్ హెడ్ కెమెరా హియర్ ఇన్ ద అదర్ థియేటర్
No, no, no. We are
Okay.
still seeing with the.
ఓకే రైట్ నో
I'm
ప్రాబ్లం
pushing the cotton ball, sir, with suction.
1 second, Madhu. We'll see how the bleeding controlled.
యా నో ప్రాబ్లం
Just 1 second and we'll come. Yeah, we are able to see your picture also.
Yes, sir.
Right,
I don't
Yeah.
think there's any
యూ
bleeding.
కెన్ సీ పిఐపి ఆల్సో వన్స్
Yeah.
దీపు
Yeah.
ఓవర్ ఐ జస్ట్ టేక్ ఎ కపుల్ ఆఫ్ మినిట్స్ ఓన్లీ
Yeah.
we will show you two varieties of tongue ties. One
Okay.
is with Colorado
So if
needle,
there is any
another is
cotton struck,
conventional.
you can just push it like this with your
Yes.
curved suction through
Yeah.
nose.
Almost no bleeding at all,
Yes, sir.
Manideep.
Yes, sir. Yes, sir.
There is no
You can see.
bleeding.
Now my always irrigate.
Acha, you irrigate after.
Yes, sir. I'll irrigate and dislodge any clots and
Okay.
see if again any bleed is there. This is essential. You
Okay.
should do it religiously for debrided adenoids.
Okay, okay. So there's a note a point.
Yes,
So
sir.
always we irrigate
Yes.
after debriding the adenoids.
Right side. But never touch the tissue.
Yeah. Without touching the tissues.
This is also crucial, sir. It's okay even if you touch the tissue, but try to not touch the tissue. Once again, I'm passing my suction from left side to right side.
Okay.
This is crucial to reach the superior part
Yeah.
of coena.
Yeah.
Irrigation, please.
You are using only normal saline.
Left side. Yes, sir. Normal saline. irrigation on right side. Right side side.
Okay, Deepu, can we
Yeah,
go
yeah,
to
yeah. Please, sir. Sir,
Dr. Madhu? We are with you. We have seen beautiful. Can we have a big applause to Dr. Manideep for the excellent demonstration of adenoidectomy by microdebrider?
Okay. Hi, I think you have enjoyed my son's
Yes.
adenotonsillectomy, which
Yeah.
is bread and butter or roti pappu for us,
Yeah.
bread and butter for Americans.
Okay.
Okay, now are you seeing the open mouth of a small child?
Yes, yes.
This is a severe tongue tie,
Yeah.
and I have put a boiled gag,
Yeah.
and anesthetist is in line.
Yeah.
ఇక్కడ ఉండాలయ్యా నువ్వు. Here I am using a tongue spatula.
Yeah.
I had given 1 cc of gelatin adrenaline already.
Okay.
కిందకి ఇట్లా అన్నాను. And take a artery forceps, press
Yeah.
the frenulum,
Yes.
and at
Sir,
the base
we
of
are
the
not
tongue.
able to see, sir.
Yes?
Camera,
Camera,
is not
camera.
focused, sir.
Yeah, focus the camera. Madam, కొద్దిగా send. I am doing under overhead camera.
Yes, sir. Ask him to come.
Closer,
Yes, sir. From above, he has to take, sir.
Is it okay?
No,
No,
sir. We are
not-
not
not.
able to see the frenulum.
No, I have not put the frenulum. Is it now seen?
No.
This is the lower teeth.
No, he is putting the camera from side. We are seeing only lips and your instruments.
He has to come to right side, sir. 2 minutes. Cameraman.
నువ్వంటే రైట్ ఇప్పుడు ఏమన్నా దగ్గరికి
Yeah,
వచ్చి-
yeah.
now we are able
I think
to-
now
yes.
it's a better picture.
యా
Yeah, now we are able to see.
పట్టుకోమ్మా కిందకి అనుకోయ్యా నౌ మై అసిస్టెంట్ ఈజ్
Yeah, now we are able to see.
కొద్దిగా ఎందుకు పట్టుకుంటున్నాను ఐ హ్యావ్ జస్ట్ compressed with artery forceps
Yeah.
and a straight scissors, and don't cut the submandibular gland
Yeah.
duct opening.
Yes, yes.
I have already cut. Now you can see, you need not suture the tongue tie.
Yeah.
And majority of the times, because of adrenaline is given, there will not be any bleeding, and now you can see the total. And in between, you can expand like this.
Yeah.
And that is all you need to do, and put a small cotton wick.
Yeah.
This is a conventional tongue tie.
Yeah.
Okay?
Madhu, Dr. Mahendra, Professor Mahendra came
Yeah,
from
yeah, yeah.
Kurnool.
I'll show you another technique with Colorado needle.
Yeah.
So that is like telling that laser tongue tie. Okay?
Okay, okay.
We'll go to the other table.
Okay.
So we want
So what is the anesthesia you have given to the child?
we have given glycopyrrolate and midazolam,
Midzolam.
and given, I think, inhalational.
Sevoflurane?
మాధవి ఇచ్చినామా సివోఫ్లోరిన్ ఏమన్నా
Have they given ketamine or sevoflurane inhalation?
No. Only midazolam and glycopyrrolate.
Okay.
అరే నువ్వు ఏడ్చకూడదు ఓకేనా సో దిస్ ఈస్ అనదర్ గర్ల్ వీ హ్యావ్ నాట్ ఎట్ గివెన్ ఎనీ
yeah.
అనస్థీషియా ఆల్సో
Okay.
హోల్ట్ అవ్వలేదు చిన్న ఇంజెక్షన్ ఇస్తాను సరేనా నొప్పి లేకుండా
Can I?
గివ్ మీ 2 cc
Hello?
సిరంజ్
PIP ఏమనండి endoscopy.
Madhu, Nashrav made a very good point. With the ketamine, there will be lockjaw, so we can't open the mouth properly.
వీ హ్యావ్ నాట్ గివెన్
Yeah.
బట్ ఇఫ్ ఇట్ ఆల్ సివోఫ్లోరిన్ యాజ్ అన్ ఇన్హలేషనల్ దట్ విల్ బి సఫిషియంట్.
Yeah.
And adults usually we can counsel. I don't know whether, I think this girl is a bit bigger. Em peru nana ni peru? No, right. 2 cc syringe.
Hello,
yeah?
Prabhakar sir.
Yes, please.
I just want to show the tonsillar fossa. I
Yeah.
will close up. So
ఇది ఉంది సరిపోతుంది.
this is the left tonsillar fossa.
Yes.
no bleed,
Yeah.
and this is right tonsillar
Very
fold.
good. Excellent.
So I've just
Excellent.
peeled.
Yeah.
This is, you can peel, and the fossa is also so beautiful.
Manideep, have you used any diathermy or any?
Nothing, sir. Not
Nothing.
at all.
Can have a big applaud for the bleedingless
Thank you,
without
thank you,
using
sir. All the
diathermy or
blessings
not, he did.
Yeah.
Good.
Thank you, sir.
Nice
I'm-
demonstration.
yeah.
Thank you, Manideep. Dr. Madhu, we are with you. You are doing under local?
Age of the child, sir?
Madhu, what is the age of the child? Manideep, you asked them to switch over mic to Dr. Madhusudan.
అయిపోయింది
బస్ అయిపోయింది ఇంకా అయిపోయింది నొప్పి ఉండదు రే we will show you with this Colorado needle.
Okay.
So what I would like to say, that is a cold, what you have seen already,
Yeah.
it's just crushing the tongue and the frenulum of the tongue tight, getting attached in between the two submandibular duct punctum.
Okay.
So the main thing is you should not damage the submandibular duct drainage system.
Okay.
So crush at the base of the tongue and just take a scissors and cut.
Okay.
And the mucosa is so nice, it gets mucosalized.
Okay.
If the incisions are big, you can take a Vicryl 40 and also put a suture. Am I the 20?
Thank you, sir. Sir,
Okay.
This tongue tie appears very simple. But
Yes.
sir, you have given a take-home message, sir. Thank you. To
No,
protect the submandibular.
No, yesterday somebody asked us, sir, why don't you show tongue tie also? That's why we have taken a decision that why can't we show tongue tie also? Though they are very simple, if you see how we can, it's very simple. Though instruments are, one is, this is tongue spatula, one artery forceps. ఇంకా మాట్లాడొద్దురా.
Sir, can you
Right,
show?
I am taking this spatula,
Yeah.
I am taking this artery forceps
Yeah.
and actually crushing the base of the tongue, okay?
Yeah. Yes.
Now, I'll just taking this Colorado needle,
Yeah. Focus.
my focusing. So I'm cutting, are you able to see the cut?
Yes, yes. No, not
Not
clear.
able to see clearly, sir.
చూడమ్మా.
Focus, focus.
Focus అయ్యా
It's
ఇక్కడ.
exposed from below. The cameraman shifts little to expose from the side or little. Now little.
Sir, camera has to be focused, sir.
వద్దయ్యా ఎందుకు వద్దు? Is it now focused?
No,
Ah,
sir.
better, sir. Better. Still, it can be.
Camera is
We are able to see, but
అరే
the
నువ్వు
focusing
ఇక్కడికి
need.
చూపించుకుని ఉన్నావయ్యా.
The
We
floor.
need focus.
Floor must be focused.
Focused.
Floor of the
ఇక్కడికి రా,
mouth.
ఈ పక్కకు రాయా. Is now focusing the floor now?
Yes, sir. Yes.
So I have already cut.
Now we could
Okay.
see your Colorado needle
Okay.
usage.
We are able to see the picture, but he is not able to focus it. Okay, it's all right. No problem.
Direction is good.
to
Madhu,
what depth you
this
can
is
go,
nothing
sir.
but monopolar artery.
Yeah, monopolar, do the.
So it is a curved needle. Curved needle.
Yeah, curved
Yeah.
needle. I just want to say,
Up to
So
what
it's a
depth you will go, sir?
diathermy. You are doing diathermy cutting.
yeah, diathermy cutting, whatever it may be.
Okay.
And see, you can, still there is a fibrous band. I just cut that.
While cutting the fibrous band,
Yeah.
Yes.
should we be in the middle of the tie or should we more towards the tongue, sir?
Towards the tongue.
Yeah. We should not injure the
we
duct
feel,
opening.
we feel we have given enough amount of mobility.
Yeah.
So we'll just put a gauze piece and close down.
Post operatively, any advice, Madhu?
No, just betadine wash,
Ah.
and routine some painkiller and antibiotics.
No,
Syrup.
no, do you advise them to do any tongue
Over.
exercises?
Huh?
Any tongue exercise,
Yes, upwards and sidewards.
upwards and sidewards tongue
That
exercise?
is because floor is already anchored right from the birth.
Yeah.
So upwards, touch your upper incisors
Oh,
and sideward movements. అరే
Yes.
నీకు ఇప్పుడు కొత్త చాక్లెట్ ఇస్తాను ఓకే అగో అందరికి హాయ్ చెప్పు హాయ్
okay, thank you.
Sir, hello, sir.
హలో
Sir, you please
Don't
pull the
switch,
tongue to the, touch the tip, sir, tip, the lip, upper lip.
Yeah.
వాట్ అప్పర్ లిప్
Yeah, it has to touch the upper lip, na, sir.
Yes.
ఆహా అరే నువ్వు పైకి తగిలిచ్చురా పంటికి పై పంటికి కాలుకి తగిలిచ్చు
పై పెదవి
ఇట నన్ను ఇగో నన్ను టచ్ అవ్వు ఇన్స్ట్రుమెంట్ తీసుకో
పై పెదవిని
ఆర్టరీ ఫోర్స్
Instrument, the
పై
యూ
పళ్ళను
వాంట్ టు చెక్ కదా
పై
Yeah,
పళ్ళను పై పెదవిని
Yeah, yeah. Yes,
ఓకే
yes.
ఆర్
Yes,
ఏబుల్
sir.
టు సీ
Yeah, 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 we can
yes,
see.
yes.
పై
Yeah.
So
పళ్ళను పై
once
Yes.
they get the exercise, they will do.
Yeah.
చూపించిన డక్స్ చూపించిన రెండు చూపించిన బోత్ సబ్లింగ్వల్
tongue may be painful when
Yeah,
he is
yeah.
holding the tooth
ఓకే అయిపోయింది I just want to show you. I
Yeah.
don't want you to do under local anesthesia also.
Yeah, yeah.
You can give under some general anesthesia or something like that. Okay.
Yeah, excellent
Sir,
demonstration.
need
Can
not
you have a
switch,
big
sir?
applaud for Dr. Madhusudan
Next
Rao?
academic.
Excellent demonstration, both under GA
Manager,
and under local
60
anesthesia.
Sir, need not be sutured, sir.
చేసేసి చాలా బాగా చేసినాం బట్ కొద్దిగా టైం తగ్గించుకో
Sir, need not suture, sir. One question. Second question, jet blast, is it superior, sir?
ఫర్ టంగ్ టై మహేంద్ర
Sir,
జెట్ప్లాస్టీ
sir, is it superior, sir?
No, with my experience, we regularly do now tongue tie is included in the Arogyasri program.
Yes, sir.
So any tongue tie comes to our hospital, we shift into the Arogyasri program.
Sir,
So I don't think any jetplasty or anything is necessary. A clean cut incision. I don't even advise Colorado needle, which can cause fibrosis.
sir.
The best is clean cut scissors and plain mucosa and it will heal off.
Sir, thank you, sir. No need to suture also, sir.
Having the tongue spatula, which has a slit in the middle, that
Yes,
that slit will hold the tongue fibrous band,
Sir.
and the two expanded tongue spatula will lift the both sides of the tongue.
Tongue, yes, sir.
So here you apply the artery forceps
Ah,
just to reduce the
Crush.
vascularity. I have already given xylocaine adrenaline
crushing
and
and cutting.
just
Crushing and cutting.
crushing and cutting. Here there is a submandibular duct opening, right and left. So you can see the edges of the opening. So avoid that and just cut. Simple cut.
Right, sir.
It's not
Advantage
like-
of Colorado cartridge, sir.
I just showed you the other method,
Right, sir.
but Colorado needle is again thermal injury.
Sir.
People are very fond of laser, everything laser. So
Towards
you
leisure. It is towards leisure.
Towards laser.
A
That's
step
all.
towards leisure. Thank you, sir. Thanks a lot, sir.
ఇక్కడ సిస్ట్ పెట్టిస్తావా రామ్
Nice show, sir. Would you like to add some info till in the break, sir? So what are the techniques you do use in your institute, sir?
Cutting with monopolar, no need not to use suture also. Nothing.
Anytime have you observed jetplasty and
No, nothing. No. For these other wall submucous fibrosis, we do jetplasty.
what is that plastic surgeons prefer in these procedures, sir?
In the jetplasty,
Jetplasty.
that's
Plastic surgeons they prefer
jetplasty.
jetplasty. Madam, would you please please
No, sir,
add
I mean-
few points for the benefit of all?
Anybody knows jetplasty for the tongue tie? They
I
can
think
enlighten.
madam must be introduced first.
Madam is the professor from Akash
Medical,
Medical
College,
College.
Devnalli.
Your good name, madam?
I'm Dr. Tejaswini.
Akash Medical College, where?
Sir, I have just seen plastic surgeon doing Z-plasty for both earlobe repair and tongue tie release from in my college.
Okay. Good.
The jetplasty we used to do in our current medical college, with the guidance of plastic surgeons, we did that. If a proper post-op exercise is not there,
It may
Again-
reunite.
it may reunite and it's like something like recurrence. So proper, so patient participation is more important for a better result. The jetplasty, by doing jetplasty, on the table itself, in the jetplasty we had to suture inevitably. That's one thing. When we suture, there is no chance of reuniting in a wrong way. So that is a advantage one. And plastic surgeons, they do, as Madam rightly told, fond of jetplasty in various parts of the body, wherever they want very much widening. Anybody in the audience can add if they have.
Dr. JP, Dr. Jaiprakash Reddy, any idea about jetplasty?
Boss, good morning. Good morning, sir.
No idea, sir.
No idea.
Actually, the jetplasty is not required for tongue
Yeah.
tie. So, it looks very simple surgery, but when you take the patient under general anesthesia, there are two issues here. Number one, we don't usually intubate the patient,
Yeah.
thinking that they're simple surgery.
Yeah.
Number two, mouth opening is a big issue.
Yeah.
So once you use a Doyne's retractor, it will be bigger for the child.
Yeah.
And third point is, when it bleeds, there is no pack that you can keep in the
Yeah.
post.
Yeah.
So these are the three problems.
Yes.
So in my practice, what I do is, I take dental blocks. I
Okay.
take dental blocks from the dental practitioner.
Okay.
There are three sizes available.
Okay.
So you can select the suitable one and keep at the retromolar area, molar
Okay.
area, so that the mouth opening will be easier with that.
What is that name? Dental?
Dental blocks they use to give the
Dental
injections.
floss, yeah.
They'll be available in the black color, sir, actually.
Yeah, yeah, yeah.
They'll be in three different sizes.
Okay.
And keep it at the retromolar area so that
Yeah.
it will get opened easily.
Okay.
Then we need to take with 10 silk, you have to take a bite to the tongue
Okay.
so that the assistant will hold the tongue upwards
Okay.
under anesthesia.
Yeah.
Then using either diathermy or radio frequency,
Okay.
you just make a cut near to the tongue surface, sir, not
Okay.
towards the floor of the mouth.
Okay. Okay.
So then we have to, actually the frendular artery is there at the end of the
Yeah.
frenum that bleeds. So we have to take a tie with the
Okay,
30 micril, sir. 2 stitches will be enough.
Okay.
Or
Okay.
if you use radio frequency, no need of,
Okay.
this is how I do, sir. No jetplasty is required.
Okay. Yeah. Usually we also all practice by using just diathermy. We can cut any. That is the name of the needle. He told Colorado. Just you can take normal diathermy monopolar and you can cut. Usually there will not be any bleeding.
Sir, the advantage of Colorado needle, what is shown here,
Yeah.
is that it is bent like this.
Yeah. Yeah. So.
So you can, what you are cutting, you can easily see. It will not come in the way of doing.
Yeah. Yeah. Yeah.
That's the advantage, sir.
So vision will be there.
It's not very expensive also.
Okay. Okay. Is it available with our people?
Yeah, it's
Around?
available. It's
Okay,
about
okay.
some
Okay.
500 or 700 rupees. That's one needle. will cost.
Yeah. Yeah. Thank you, JP, for your enlightenment.
Thank you.
Thank you, sir. Sir, what sir told is, it's not dental floss, it's the dental blocks. They have to be kept in between the jaws.
Dental blocks.
At the molar level, in between the two jaws. That's almost fixed opening would be there. We used to do that. And with the jetplasty, when we came to know about that in the initial stage, we used to prefer to do that. Only thing is, more enthusiastic jetplasty may sometimes may, if not care is not taken, likely to injure these sublingual or submandibular salivary, submandibular glands. So that's the care where we have to be taken, that's all. And post-oply, one is exercise was told, another is proper pain reliever has to be given. Otherwise, because of the post-op pain, the child keeps without opening, without tongue movements, that also leads to reunion.
Operation theatre.
Are you able to hear me?
Yes, Madhu,
Yes,
we are
sir.
with you.
Yeah, are you able to see a small cyst in the right side of the cheek?
No. Picture,
Now
yeah.
we got, yes sir.
Salivary sister. What is that?
No, it may be a minor salivary gland cyst.
Minor salivary gland cyst.
This is the right side of the cheek. A Doyne's retractor is there.
Yes.
This is almost 1 centimeter cyst. I just want to show even how the small cyst can be removed.
Yeah.
Okay?
Yes.
Is it clear for you?
Yes, we are able to see.
So we give an elliptical incision
Yeah.
and give like this
Yes.
and come to the anterior surface
Yes.
and take the same incision on the opposite side. Give me
Yeah.
2 forceps. Right. My assistant will hold and now I'll combine these 2 incisions. Right. Give me an artery forceps. You can take and suction is there. So you can take an artery forceps and hold this and now take a sharp knife. And now I am just reducing and cutting the entire base of this gland.
Yes.
Okay? And put a gauze piece. Now you can see the gland which was seeing, are you able to see the gland cut?
Yes.
And this is the base of the gland.
Yeah.
And very simple, take a 3-0 mer silk. True
Madhu,
silk, mer silk.
Is there any need to send to biopsy?
Yes. Compulsory.
sending?
We have to send it to the biopsy. Not much bleeding, I think you are able to see. Once you
Yes.
put 2 sutures, it will just. ఇప్పుడు రియా చూపించినాడు చూడయ్యా మర్ సిల్క్.
I think you have infiltrated. You have given local infiltration.
Yeah, local infiltration. Local infiltration I have given. I given 5 cc of simple xylacane with 2000 adrenaline.
Okay.
No pre-medication, no IV fluids, nothing. Vicryl. Vicryl absorb అయిపోతుంది. Okay, right. I'm sorry. And actually, I thought of putting silk, but Vidyasagar is beside me telling, Madhu, put a Vicryl.
Okay.
Because I thought Vicryl sometimes get wet and get absorbed. Then that is
Yeah.
also an advantage, Madhu. It gets
No.
absorbed.
Vidyasagar is in a rich area.
No, it's not the richness. I am taking a bite from here, and my Manideep is assisting. He will take the needle, and we will just take.
Usually you use silk, Madhu, normally,
Yes.
and you will remove it after 1 week.
1 week. I thought one thing is economy, not economy, but I thought it will become loose, Vicryl.
Yeah.
Vicryl is
But
costly.
Catgut will always become loose and it may
Yeah.
slip off also, but Vicryl doesn't. Because he has a vast experience in doing uvulo-palato, modified
Yeah.
gitaplasty. We will give another small cut like this, okay?
Yeah. Any suggestion that Vicryl should not slip? How many knots we have to apply?
No, double knot.
Double knot?
I think that is more than sufficient. We will show you another case like this. Papa, vachinde? Right.
So Vicryl is definitely more convenient. patient acceptance will be better. Only thing is it little costlier. More cheaper is catgut, but catgut would be like a wire, it would be pricking for the patient.
See,
That
now
is it.
with these two sutures,
Yeah.
it's almost nice approximation and that should not cause much problem at all to the patient. Okay?
Yes. Yes.
So, what mean is, these are all things, even a budding ENT surgeon should not feel, I will get more amount of bleeding or something.
Yeah.
So, this patient is well under conscious, just xylocaine, adrenaline, without any fluids and everything, but Ravi Krishna and Madhavi are still with us. Okay?
Yeah.
Right.
Thank you, Madhu,
No,
for the
thank you,
nice
thank you.
demonstration of basic things
Yeah.
like tongue tie and cyst.
Right. And next is a adenoidectomy.
Okay.
సతీష్ చేస్తాడు కదా దీపు ఇది నేను చేయమంటావా దిస్ ఈస్ ఏ కేస్ ఆఫ్ 13 years old girl.
Okay.
పేరు దీక్షిత.
Okay.
And this Dikshita had a really snoring complaint of the snoring. And can you show this CT scan? You are able to see the CT
Yes.
scan?
Yes.
This is the scout and gout film.
Yeah.
And you can see a prominent incisors.
Yeah. Yeah.
This itself shows.
Yes.
And if you can measure the nasopharyngeal airway
Yeah.
from the skull base
Yeah.
to the upper surface of the palate,
Yeah.
in that more than 80% of the space is being occupied by the mass of nasopharynx.
Okay.
Once the patient lie down, this is in erect position,
Yeah.
lies down, the uvula and soft palate gets attached and naturally this patient goes into obstructive syndrome.
Okay.
And incidentally there is a deviation of the
Nasal septum.
nasal septum. But we are not thinking of this nasal septum is causative for her nose obstruction. This is there maybe from the age of 6 or 7 years and going on.
Yeah.
So at the present moment, sinuses are almost all clear.
Yeah.
And adenoids, you can see here, ingoka film undamma,
Yeah. The coronal cut also.
coronal cut. ఇది ఇంకొక ఫిల్మ్ ఉందా ఈ పాపది దీక్షితది
We are able to see nicely, Madhu.
Acha, then okay, because
Yeah.
this is almost like a surgical cut.
Yeah.
So you are able to see, and it's only the compensatory hypertrophy of inferior turbinates.
Yeah.
And this is the sagittal, almost you can see in the midline,
Yeah.
it's almost occupying the whole nasopharyngeal
Yes. Yes.
space.
Yeah.
Otherwise, all the sinuses are well in clear.
Yeah.
So again, we are going to show you another adenoidectomy in a simple way, so that all varieties of adenotonsillectomies will be over for today. And the next case will be Dr. Satish Jain will be starting an extensive phase,
Okay.
unimaginable polyps, osteitis and infection of an young girl, multiple ethmoidal polyps and
Madhu,
chronic. Yes.
are you using still adenoid curate? No.
No.
In medical colleges, madam, are you using adenoid curate?
No, if at all you want to do Arogyasri,
Yeah.
there is this thing when you do not want to, naturally in Arogyasri, you don't want to spend money. In such cases, still it works out.
No. In medical colleges, they are using still
There
adenoid curate.
Mahendra is there,
Yeah.
and Tejaswini, I think from Bangalore, Asha is.
Yeah.
And
Sir, we have been using adenoid curate.
Sir,
Okay.
As long as it is not stolen, we may be using. It's not available, sir.
in our medical college, I
Sagar,
am
you are
using
using adenoid
microdebrider. sir.
curate till?
Microdebrider.
No.
Yeah.
In our medical college, I am using microdebrider. Very beautiful, time consuming, bleeding is very less and more accurate removal of the adenoids.
After adenoids, how you are controlling bleeding natural?
No bleeding with debrider, sir.
No.
Just-
Are you using this paracrium?
Huh?
Paracrium liquid are you using?
No, nothing. Normal saline, warm saline we use.
Only warm saline?
Warm saline.
Okay,
Warm
good.
saline means 37 degree room temperature.
Okay.
Sir, Madhu sir, small question here.
Tell me.
This patient is having gross adenoids.
Yes.
Again, there is a gross deviate nasal septum.
Yes.
The patient came with difficulty in nose breathing.
Yes.
Am I clear?
Yes.
do you give guarantee of relief of the breathing symptoms after only you do the adenoidectomy in this patient? Because there is a DNS.
Very wonderful question, Nageswar Rao.
Yes, sir.
And I also love to answer.
Yes, sir.
Number one, any child is snoring cannot be attributed to any amount of deflected nasal septum.
Sir.
Snoring is only, I think, majority of 95% of snoring is due to the nasopharyngeal junction.
Okay, okay.
So, if you remove the adenoids and the patient snoring goes off, in spite of having that deflected septum, that will not cause snoring because the septum blocks one side. The other side is there, na? Body
Yeah.
septum phenomena, deflection did not happen in a day process.
I'm not asking about the snoring, sir, but difficulty in nose breathing. Still,
Yeah.
They will be acclimatized.
yes.
And she's a small child, Dikshita. So pediatric septoplasty has come into actually pediatric FES. We have kept one case today also, I think pediatric FES. You can ask Satish Jain.
Yes, sir.
What are the limitations to do a pediatric FES? What to do? You want to do a wide middle metal antrostomies and wide dissection of bulla ethmoidalis, remove the total uncinate, go like all this, you know.
No,
It
Madhu,
has-
yeah, you are right. Majority of the cases when we see huge adenoids, we see CT scan, there's a severe sinusitis, pan-sinusitis.
Yes.
But usually we don't touch sinuses. Just by doing adenoidectomy, everything will be regress.
For us, in spite of all these things, to be doubly sure, routine antral wash cannulas, pediatric antral cannulas, trocar.
Okay.
So you just put into the inferior turbinate, press, just push. If then any mucopus just comes into the nose.
Okay, okay.
So adenoidectomy itself can give a good mucokinetic, mucoregulatory, and mucostimulatory,
Okay.
like ambroxyl or acetylcysteine combination with antihistamines are coming.
Yeah.
You give and naturally the circulatory phenomena will increase and all the secretions will come out.
Yeah. Thank you.
Right.
Thank you, Madhu.
Right.
Yeah.
Sir, is it the child, is it just simply a snoring case or is it a diagnosed case of OSA, sir?
Diagnosis case of?
OSA?
Yeah.
As a
It's an
simple
obstructive airway with snoring, but it's a level 1. See, when Vidyasagar is there, I am not sure. See, you know, level 1 is up to nose and nasopharynx. Level 2 means when you open the mouth, Friedman's position or whatever positions of tongue base, pillars, soft palate, uvula, palatopharyngeal folds, posterior pharyngeal wall, tongue, all will come under level 2. Once you cross this base of the tongue, till the vocal cords, almost you should consider as level 3. Level 3 is very dangerous. Even I don't do anything because you need a assisting airway like tracheostomy when you are doing a level 3.
Yeah.
A simple gross adenoids and snoring, it's a level 1.
Okay.
Remove the adenoids and his snoring disappears. That's all. No
Okay.
issues at all. If the child has a big grade 4 tonsils, so naturally you remove those tonsils and even level 1, level 2 is also attended. That will really give a very good relief. Even you can eustachian tube, C-type or B-type of your impedance, put a grommet tube. So you are operating on the nose, operating on the throat, operating on the ear, combined. Sagar, you want to?
Madhu?
I think sir is.
Yeah, Sagar,
Hi,
please.
sir. Good morning.
Good morning.
Sir, nice to meet you all. It's a pleasure to be with sir's OT all the time. So I think sir has nailed it very clearly that even in pediatric OSA, you have to identify the level of obstruction, type of obstruction, and severity of the collapse. And what is contributing for the obstruction is the most important thing. So he has very beautifully told that in this particular patient, adenoid is the one that is the culprit. So just remove the adenoids and see how the child is doing. That itself is enough. In pediatric, I think pediatric OSA is a big topic that we can talk for hours. But in pediatric OSA, if you have a documented evidence of witness apnea, even more than 1 per hour, it is considered a positive for pediatric OSA. So almost 80 to 90% of the pediatric OSA gets treated with your adenoid and tonsil surgeries if they are the most important culprits in that. In spite of them, if there is, you have done a adenoidectomy and tonsillectomy, and in spite of that, if you have the patient suffering from snoring or sleep apnea, then you have a gamut of array of evaluations that you need to do. That you can do it later, and then you can decide what next to be done for that particular patient. One particular thing that I would definitely look in before doing a adenoid in this patient is look at the arch of the palate, whether the palate is high arched or not. If it is high arched palate, then we have so many procedures that has come into vogue now. You have to think about the dome procedure or SARME. I think we have discussed all this in the recently concluded IASSA Con, wherein that also plays to improve your nasal breathing.
Yeah, Sagar.
Yes, sir.
If you don't mind, can you expand that words, mandibular advancement and palatal expansion?
Yes, sir. So the rapid maxillary expansion.
Rapid maxillary expansion.
So this rapid maxillary expansion plays
By
a role.
surgically or by prosthesis?
Yeah. So if you do it by surgically, then we call it a SARME. And I will expand it later, sir.
Yeah.
But because Deepu is about to start.
Okay.
What I will tell is, like, if the patient is having a high-arched palate, then with your dental colleagues, the pediatric prosthodontist, you can place a small prosthesis in the palate, and you can slowly do a distraction osteogenesis.
Yes.
That is like you are going to expand your palate, for which your mid-palatine suture has to be opened up. So that we open it surgically also. So what it does, by making mid-sagittal cuts, then you keep your expansional device there, that you can anchor it to your palate or to the process itself. There are 2 types that are available. And slowly, post-operatively, after a period of 14 to 21 days, you slowly expand that screws.
Yeah.
That will actually widen your palate, and it will reduce the height of the arch. So that itself will open the nasal breathing.
Nasal airway.
Nasal airway.
Yeah.
So that is one thing that you need to consider whenever you are seeing this pediatric OSA patients.
Yes.
So take a look at the adenoid, but also look whether the patient is having a high-arch palate, both clinically as well as in the radiologically.
Yeah.
So
Sagar, thank you very much for the excellent explanation regarding the expansion of the palate and increasing the airway of the nose.
yes, sir. Thank you,
you.
sir. I think now Deepu will take over.
Yes, sir. Sir, Dr. Sagar garu.
Dr. Deepu?
Sir, hi sir.
Yeah, we are with you.
Yes sir, good. Okay. You're getting the endoscopic picture, sir?
Yes, yes.
So this patient has a DNS also, so it will be a little bit tough to pass the scope, but I'll try to.
Yeah, yeah.
Ah.
Yeah. Dr. Manideep,
Sir,
we want to see how the setup, because a lot of audience now, they want to see setup of the operation theater table and surgeon, how he is standing or
Okay.
sitting,
yeah.
and how
No,
you are
I'm
holding the
standing.
instruments.
External camera, PIP ichesandi.
Yeah.
Yes.
Just show. Thank
sir,
you.
yes, sir. One
Acha,
second.
you applied a mouth gag?
Yes sir. I applied the mouth gag.
Yes. Yes, we are able to see.
Yeah. So for debrided adenoids, it's important that you are, as we will not put just for adenoidectomy,
Yeah.
without tonsillectomy, as we will not be in rose position, It will be also easy to pass the scope and instrumentation, sir, because the bipods will not come in the way.
Yeah.
But the only thing is the gag will relax here. So
Okay.
I've seen some surgeons put a bowl here,
Yeah.
or better than that,
Put a cup. Yeah.
If not, tell your assistant to hold the gag still, like
Yeah,
pull
yeah.
more anteriorly.
Okay.
This is also fine, and also you can put a cup like
Good,
this.
good idea.
Yeah. So once again, so if any audience missed out, shall I again go about the eustachian tube anatomy, or shall I start?
You can. I think because at that time not many people were there.
Okay, sir.
Now everybody, you can also talk.
Okay. Yes, sir. Yes, sir. Yeah.
Sir, I think you are
Sir,
asking the expansion of SARME and SARPE, sir. Is that what you are asking, sir?
No.
In that time,
No.
SARME is surgically assisted rapid maxillary expansion.
Surgically assisted
SARME.
rapid maxillary expansion.
Yeah.
Okay,
And
sorry.
the other one is SARPE,
SARPE.
surgically assisted
Ballpoint
rapid
like
palatal expansion.
Rapid palatal expansion.
So these are the two words that you need to remember.
Okay.
Okay, sir.
Yeah, Dr. Manideep,
Sir.
we are with you.
Yes, sir. Okay, I'll explain the eustachian tube anatomy once again.
Okay.
So, okay, I'll have this ball point. So it
Yeah,
will
we are
be-
able to see clearly
Yes, sir.
endoscopic picture.
Yes, sir. Just a minute, sir. Taking ball point. So, the most prominent part of the eustachian tube is called the torus.
Yeah, Dr. Manideep,
Sir.
the small announcement is
A
going
small
on. 1
announcement.
second.
Yeah.
Yeah.
Cars by numbers 2536 3007. They are parked in front of the pesticide shop, which is obstructing their entry. Can you please move the cars? Cars numbers 2536 and 3007.
Dr. Manideep,
Yes, sir.
yeah, we are with you.
So, sir, the main important parts of the eustachian tube are the torus tubaris, the bulge
Torus
of the...
tubaris.
Yes, sir.
Yeah.
So, torus means the bulge,
Yes.
tubaris means the tube. So,
Tube.
torus tubaris.
Okay.
Then why I am stressing the folds is because I have shown you in the earlier case, I will explain again. The medial border of the eustachian tube is called salpingopharyngeal fold.
Okay.
As I have explained the etymology, the origin of each medical word, it's the signs of origin of each medical word as it is derived from Latin is called etymology.
Yeah.
So salpinx means tube,
Salping means tube.
pharynx. So the fold that is in relation to the pharynx, the
Yeah.
medial edge is called as salpingopharyngeal
Pharyngeal fold.
The lateral fold of the eustachian tube is called salpingo-palatine fold because it's in relation to the palate. And the inferior bulge, as I am pulling it up with ball point, this is the levator fold,
Yeah.
which is the mucosal surface, the dorsal mucosal surface of the levator valli palatini muscle,
Yeah.
which pulls the soft palate, hence the name levate villi. It covers the palate and it is a palate muscle. So
Yeah.
levator valli palatini. If you want to remember anatomy without forgetting, it is pertinent that we go to the etymology, know what does that mean, because it's not in English, so
Yeah.
it's in Latin. So know what that means, then you can never forget what the complicated anatomical structures are.
Yes.
You need not by heart, sir. So
Yeah.
why I am stressing is, we will debride this medial border of the only salpingopharyngeal fold.
Yeah.
So, yeah. Now, I think so, I am also able to see the opposite side also, the eustachian tube with 0 degrees only, sir. I think so, you can like see the hint of the medial edge of the salpingopharyngeal fold on the opposite side.
Yes.
So, once again, I will show how I enter. As the Boyle-Davis mouth gag will always be in center, and our adenoid blade cutting surface, as we use rad adenoid blade, which is on the opposite side. So we go from right and then pull the palate up. The first advantage of this technique is you can easily pull up the soft palate without injuring the soft palate, as the cutting surface is on the opposite side. Now go with a straight 0 degree. As I am going from lateral opposite side, I am able to pass up to the opposite choanal superior surface. And now I debride. So let the tissue come into the blade. This is important. So go down, debride. So as I didn't explain the resistance phase, sir, as in this technique it is more of seeing and also palpating with your blade how much resistance. Now I am facing a little bit of more resistance from the tissue. Now I am trying to touch the tissue but also be gentle, like hovering. But here in the lymphoid follicle phase, the adenoids, it comes easily. It's like a soft jelly type. So you will be able to appreciate that you need not put any pressure on the blade to debride. So now I will rotate to debride the medial edge, just the medial edge. See, again I am not touching the tube, I am letting the tube come to me. So debride up to perimysium, which again is important, as Satish Jain sir will again show how he gets to the perimysium with a reverse 60 degrees blade. Sir's technique is excellent, but it takes certain level of skill to maneuver the blade. This doesn't, because as I told earlier, this works with the gravity. I am having the help of gravity with me. In the other technique, you have to go against the gravity. The third part, I can able to lift the eustachian tube with my blade and also get a glimpse and then debride the force of Rosenmuller. In this step, it is important that you hover the blade over the tissue. Never go deep into the tissue. Just let the tissue come. So I have debrided. So now I will go to the opposite side, sir. Yeah. As there is comfortable space, actually I didn't go to the opposite side, sir.
Yes, yes.
But in case of a narrow nasopharynx, you, especially in children, you have to shift your blade to the opposite side to debride on the right part. So this is the advantage of our technique, and we reach up to the perimysium. So whenever I feel more resistance from the tissue, that's when I know I've reached the fibrous part of the adenoids, which is over the perimysium. Then I'll be so careful not to, I've stopped, not to poke like this into the muscle. This is important. It's like elevate, you have to hover, same like coblation, how Vidyasagar sir has shown, we do not touch the tissue. So again, I'll lift the eustachian tube and then slowly.
In the coblation, we do not touch the tissue, but in
Sir,
debrider,
I mean,
we
we have to touch the tissue, but we'll let the tissue come to us, sir. Not
Right.
like actively go and then debride.
Okay.
Yeah. So here I'll debride up to Prasavan stage. Yeah. Okay, sir. I think so I've done enough job. I'll now pack with cotton balls. My assistant will take, drop it into the mouth and then push with the tongue into the choana, which is coated with the ferracrylium, which is a surface hemostatic agent. You can already see the color of the blood change. It's becoming a whitish color, sir. So that is how it stops the bleeding, and this is good for adenoids, as adenoids bleed is a capillary bleed, not venous or arterial or muscle bleed. So we can easily stop with pressure and not with gauze or anything, sir. Cotton ball is good because the cotton ball is a firm structure which will put pressure more on the muscle. So we are taking two things at once, like the surface hemostatic help and also the pressure hemostatic help. And once again, my assistant just pushes the cotton ball for a tight pressure effect. You can see the bulge of the soft palate too, and we relax the gag and we wait for the clotting time to happen. So right now it's 10:09:38. Let's say I put the cotton balls at 10:09 a.m. here. So we'll wait for at least 5 to 7 minutes, sir. It is important. Again, debrider adenoids is more of waiting than doing for the hemostasis to happen. So I just want to show the external picture. So let's say,
Yes, yes, we are able to
it's
see.
visible, very clear.
so sir, when let's say this is my koyana, I come from here, so the adenoids is like this. I'm debriding and my blade easily goes, I mean the tissue easily comes. But once I reach the fibrous part, you can see even my glove is exerting certain resistance onto the blade. That is when you should feel the pressure, the resistance onto the blade, and be careful in your debridement. If you even then go deep into the tissue, then you will have more chances of injuring the muscle. So these three resistances, and the muscle will have highest resistance. So there will be initially no resistance at all, then you will feel firm resistance like this. You can able to see the glove is affecting, but once you press deep like this into the muscle, the resistance will be more. So seeing, and also in this technique of with our rad adenoid blade, it is important to understand this resistance so that you can easily glide your blade. And I am debriding in the center part like this. You can see I am rotating to debride the medial edge of the salpingo-pharyngeal fold. Again, when I am doing on the left side, I will be able to debride the medial edge of the salpingo-pharyngeal fold. So these few things make our technique as the advantages of it. The only disadvantage is you cannot never see the cutting edge. I agree that. But with all these points in our mind, I think so we can debride safely without causing any injury. Even a beginner can do. Satish Jain sir has come. Sir, welcome to our OT. Namaste. So sir will start the case. Thank you so much, sir. Yes.
Safe debriding.
Yes, sir.
Keeping
Safe
in,
debriding
keeping in,
is
Excellent,
keeping
excellent,
in
Manideep.
all senses.
Yes,
Excellent demo, Dr.
Thank you, sir.
Manideep.
So just to advocate our technique, the advantages and pros of our technique, why not even seeing the surface is also not bad. Yes, it is always important to see the debriding blade surface, but sir will show how beautifully he creates the plane from Passavant's ridge. He passes it, he presses on the perimysium. It's a feast to watch, sir. I love Satish Jain sir debrider technique, but as my father has taught me this, I've observed these nuances of why this technique is also good and why anybody can do this. So these are all few points. First point, once again I reiterate, we can easily pass without injuring the soft palate because the cutting surface is opposite, and the tissue can easily come